Um, so I was asked to speak to you guys tonight, and I'm really happy to. But I'm talking about global health, which I think is kind of interesting for discussion when a lot of people may not do a lot of international medicine. But what I want to focus on today is how global health really isn't always that global. We see a lot of things here. Dr. Todd literally just said how we don't encounter a lot of parasites here, so we may not have to worry about the side effects of Dupixent regarding that. And that may be true. It very well may be true, but we do encounter global diseases all the time, and they're probably going to be more and more prevalent. So we're going to touch on some of that today. I don't have any disclosures or conflicts of interest. Um, so in terms of global topics that may affect us in Louisville, I need to put things in perspective a little bit before we talk about certain things. So I want to talk about how disease spreads and how do we control disease spread with vaccines. And we're going to talk about some new hot vaccine information. And then I want to talk about what happens when we don't control disease spread and how global spread of disease affects the US burden of disease. So once a new pathogen has introduced itself into the human ecosystem, it relies on spread. Um, and to spread, it relies on a number of factors. So we're going to discuss a few concepts that allow for the spread of a dangerous disease. The environment, the life cycle of a pathogen, human behavior, the reproductive rate of a pathogen, and our response to infection all factor into an outbreak's development. So tick-borne relapsing fever, probably nothing that most people here have seen before in real life. It's one of the most frequent bacterial diseases in Africa, and it's transmitted by the bite of the Ornithodoros tick. In endemic areas, small mammals dig burrows into dry soil, and they use those burrows as housing. And then those burrows become colonized with ticks who are looking for shelter in blood meals. And since many of the tick-infested burrows are close to where humans live and work, many people are at risk at getting bitten and becoming ill with tick-borne relapsing fever. And I promise there's a point to me talking about this that will affect us. This map shows different research sites looking for tick relapsing fever. The red dots show where tick relapsing fever was found, and the blue dots are sites without disease. You can see that the cases were clustered around the edges of the Sahara Desert. Now, remember, I just told you that small mammals tend to burrow underground in dry conditions, desert-like conditions, and this burrowing exposes them to more ticks. Well, the Sahara has been expanding. And when climate change and drought expands, more small mammals will continue to burrow in more areas and potentially increase the tick-borne disease spread. So why am I discussing tick-borne relapsing fever? It hasn't really been in the news lately, and it's unlikely to be seen here in clinics in Kentucky. Well, it's because we need to look globally to see what happens domestically. There are many similarities between global disease spread and domestic spread, and climate change is rapidly affecting our preconceived notions of where specific diseases are endemic. So diseases due to climate change isn't just affecting African deserts. In the US, one of the most prevalent tick-borne diseases is Lyme disease. All of the dots on the map here are cases of Lyme disease in 2001. And it looks like a lot of Lyme, right? Well, that was nothing compared to 2 decades later. Lyme disease spread north and westward at a rapid rate. This is due to climate change, allowing for a broader habitat of the Ixodes scapularis tick. So changing tick habitat has allowed for massive spread. So why haven't we heard about like a pandemic tick-borne disease if there's such massive spread happening? Well, that's because tick-borne disease doesn't spread from human to human. It only spreads from human to humans from tick bites. And most people aren't getting a lot of tick bites very often. That is, unless climate change alters that. So tick-borne diseases are a zoonotic infection, which is propagated by a changing environment. Both the vector encounter and the growing habitat of that vector are risk factors, but the absolute risk of encountering transmittable infection is pretty low. So it's never become a pandemic. In the mid-14th century, Europe had one of the worst pandemics of all time. It's called the Black Death. And the pandemic was caused by a bacteria called Yersinia pestis, which causes plague. And the map shown looks at the spread of plague, encompassing all of Europe, much of North Africa, and Asia. So bubonic plague is spread from flea bites, fleas that come from mice and from cats. And in a 14th century city with poor hygiene and poor sanitation, these fleas can be everywhere. And the chance of a bite is high. In addition, humans can spread plague to each other via aerosolized droplets known as pneumonic plague. So between fleas from mice and from cats and human droplets, the chance of plague transmission and spread was really high. But it's not just disease exposure which propagates spread. It's also the biology of the pathogen, which plays a large role. So how do we determine what that is? There's something called R naught. R naught, which you may have heard of during COVID, is the reproduction number of a disease. It uses serologic and epidemiologic data as well as theoretical models. And these models look at transmissibility of disease. It looks at human behavior, contact between sick and healthy people, and the models also factor in where an outbreak occurs geographically. In essence, R naught aims to tell us that for every person infected, how many people will a disease spread to? If R naught is less than 1, the disease will die out, and if it's greater than 1, it will spread. So here we have a picture of the R naught of measles, Ebola, and influenza. Measles, which is often considered to be the most infectious of diseases, has an R naught of up to 18, which means that for every person infected, they may spread measles to 18 other people. And it spreads exponentially quickly. So why isn't measles everywhere? Well, that's because of something called RE, the effective reproductive number. This accounts for immunity in a population, namely previous protection, previous infection, or previous vaccines. RE is R naught times X, and X is the percent of people who are susceptible. If RE is less than 1, the disease dies out due to herd immunity. Measles is an example of herd immunity in the success of vaccines. So measles is a disease with a high R naught and a low R due to vaccination programs. Measles has declined significantly and is only seen in sporadic outbreaks. But those sporadic outbreaks are becoming more frequent. Worldwide, we are seeing an increase in measles outbreaks. Why is that? Well, we have seen lapses in vaccination programs. Since COVID, we've seen a dramatic decrease in routine childhood vaccines. This leads to a dramatic rise in vaccine-preventable disease outbreaks. In 2023, we saw 58 cases of measles in the United States, with 4 instances of outbreaks. But as of July 11th, 2024, there's already been 167 cases and 13 outbreaks in 23 different states. So a huge rise compared to last year. This is a direct result of poor vaccination rates. So what happens when there's a disease outbreak? This is a global health discussion, so I want to take a look at a global health situation, but it may translate pretty well to the US in certain instances. So imagine you're seeing a patient in sub-Saharan Africa, a 17-year-old female with fever, diarrhea, retinal hemorrhages, and altered mental status. You take her blood and you smear it on a microscope, and you stain that plate with Giemsa, and you see Plasmodium falciparum parasites. Some of you may know what the diagnosis is. Cerebral malaria is a pretty good option. So let's say we diagnose her with cerebral malaria. You treat her with IV artesunate, but after 3 days, she develops coffee ground emesis and hematuria. And this seems a bit unusual for a course of malaria. So maybe it's something else in addition to malaria. This could be something like yellow fever. Unfortunately, yellow fever can be quite fatal, and on day 7 of illness, she develops melena, shock, and she passes away. 3 days later, a few of her nurses are reported to be ill. They have headache, they have fever, they have petechiae, and it seems to be that her close contacts were sick, which indicates likely human-to-human spread. However, yellow fever isn't transmitted by humans. It's transmitted by mosquitoes. So it's probably not yellow fever. It could be something else that's spread human to human. The issue is that now we have people out in the community potentially infecting others, and they've been doing this for days. And they may have gone to school, stores, family gatherings, really anywhere. And we see this type of exposure and spread all the time during cold and flu season. And that for every hour there is community spread, the number of infected climb. With typical infections like cold and flu that we're used to handling, this scenario may or may not be so bad. But what if we're dealing with a more dangerous and unusual pathogen? This patient had some very concerning symptoms. They were deadly. Her symptoms were hemorrhagic, and maybe we're dealing something more uncommon than malaria or yellow fever. Maybe we're dealing with something such as Ebola virus. And if you think you have a case of Ebola virus, you should probably tell somebody about it. So who do you tell? So global surveillance of disease outbreak relies on cooperation and trust as there is no central governing body. Outbreak response must be coordinated amongst organizations that have mutually decided to work together. And if there's a lack of country-specific participation, if your country doesn't want to tell anyone about this, the only repercussion is bad health outcomes. There's no overseeing body. It's similar with domestic surveillance. The CDC relies on providers and microbiologists to alert them to potential emerging pathogens. Once a pathogen is identified, the CDC then tells local public health officials. Each country has their own method of communicating with local agencies. The CDC in the US uses the Epidemic Exchange and the Health Alert Network. Similarly, in Europe, there's something called the Early Warning and Response System. And globally, the WHO shares information through disease outbreak news on the WHO website. So back to Ebola virus. In December of 2013, there was an 18-month-old male in Guinea who contracted Ebola virus disease after a bat exposure. By March 10th of 2014, the Guinea Ministry of Health put out an alert that clusters of a mysterious disease characterized by fever, severe diarrhea, vomiting, and apparently high fatality rate. By March 22nd, the WHO announced an outbreak. So from 2014 to 2016, Ebola spread in West Africa from Guinea to Liberia and to Sierra Leone. And there were cases that reached Europe and North America. So if we have global surveillance, why did it last so long and why was it not contained? Well, Ebola in West Africa primarily happened in 3 of the poorest countries of the world. They were dealing with domestic turmoil and had a lack of doctors, less than 1 per 100,000. So for reference, the US has about 2,600 physicians per 100,000 people. So a huge difference. And this is why it's important to keep our healthcare afloat. To respond to an Ebola outbreak, a strong infrastructure and a unified message is needed, and that did not occur as health systems weren't prepared, culture and politics hindered the response, and there was not direct messaging about what to do, and people were focused on surviving life in general, not Ebola. And you could see this happening in other countries, including the US. People may not be focused on disease processes, may not be focused on an outbreak response, and may be focused on just surviving life. Doesn't matter if you're in a poor country or not. The epidemic of Ebola virus disproportionately affected areas with less resources available to them. So fast forward to 2021, from February to June, there were 16 cases of Ebola virus disease and 12 deaths. A large vaccination response was implemented. 2 vaccines were available, one from Merck and one from Janssen, and they're still available. So how do we use these vaccines effectively, and what are strategies for future outbreak vaccination programs? And we could take these lessons and put them into context for outbreaks in the US that we will undoubtedly see. Since the 1970s and the discovery of Ebola viruses, there have been less than 30 outbreaks and less than 40,000 cases. So it's not a lot of cases. And the area where Ebola is endemic comprises 500 million people, so a really large area. But I just told you there's been relatively few outbreaks. So with so many people and so few outbreaks, it's really tough for a low-resource economy to justify the cost of routine vaccination in a depleted healthcare system. But outbreaks are very devastating, and they have massive health and economic burdens. And so there are strategies we can try for vaccination other than just vaccinating everyone, which is ideal. One approach is vaccinating hotspot areas, places likely to have outbreaks. This isn't ideal because Ebola outbreaks have a very complex ecology and they're really difficult to predict. Typically, outbreaks don't happen more than once in the same discrete area, and human influences are a major wildcard on where these happen. So a well-known and utilized strategy used in previous Ebola outbreaks was called ring vaccination. This is where cases are identified and first and second degree contacts are immunized. The problem with ring vaccination is that cases must all be identified and identified quickly, or else the pathogen escapes that ring. It could be difficult to justify to some people why others get the vaccine and some do not. So this model has slowed disease spread in the past, but it hasn't been able to really completely stop it most of the time. So we've discussed vaccinating hotspot regions as well as ring vaccinations, and when they both have their pros and cons. And the most effective method is probably a combination of both of those, as well as vaccinating high-risk individuals, such as healthcare and frontline workers. A potential strategy includes vaccinating sex partners of survivors, because Ebola could be spread sexually after recovery. And an important step would be to initiate outbreak vaccination campaigns, which may help create a strong community response to vaccines. And then when it's all said and done, we'd want to vaccinate as many possible people in the region, even after the outbreak is over. So in terms of outbreak response, there are surveillance and vaccination techniques that we've discussed, and there are also specific treatments and public health measures that are pathogen specific. So I won't go into all those today, but they do play an enormous role in how an outbreak evolves. So we've talked a lot about how disease spreads and how outbreaks develop. Because of these factors, we've seen disease spread into areas previously non-endemic. We have seen disease spread due to movement of pests and climate change, but we've also seen disease spread due to movement of people. Historically, travel has been a major cause of disease transmission. The red path shows the spread of leprosy, and the blue path shows the spread of smallpox. All of this from human exploration, migration, and trade. Malaria, which is shown in yellow, originated in the region of what is now the Dominican Republic. It is now spread to most of the tropical world. Travel is always evolving faster and faster, and this in turn allows for disease to spread rapidly. In fact, air travel has increased fourfold in the last 30 years and only seems to be increasing. The risk of any human-to-human transmitted disease greatly rises as people throughout the entire world are interacting. We have a wonderful and robust immigrant and refugee population here in Louisville. From 2018 to 2022, we had nearly 16,000 immigrants and refugees. That's a lot of human movement from other areas of the world that we as local providers will be taking care of. Often people that move here from other parts of the world come from malaria endemic areas. Malaria is responsible for about 600,000 deaths per year, the majority of which are in children. There's about $12 billion lost in annual productivity worldwide directly due to malaria disease. Countries which are endemic to malaria have about 70% lower per capita income than non-endemic areas. And countries that are endemic to malaria often have about 40% of their public health budget allocated to deal with malaria disease. This is an enormous burden on the healthcare systems worldwide. So let's go back to climate change for a second, because this is all interconnected. And I want to talk about malaria and climate change. Malaria is transmitted by the Anopheles mosquito, and it has not been endemic in the United States since the 1950s. There are about 2,000 cases of malaria diagnosed in the US every year, nearly all of which were acquired abroad. However, in 2023, there's been 10 locally transmitted cases of Plasmodium vivax in Florida, Texas, and Arkansas. This is now domestic, as well as one case of P. falciparum in Maryland. This is the first instance of local transmission noted since 2003. Undoubtedly, this is due in large part to an expanding habitat of the Anopheles mosquito due to climate change. This is something we may have to deal with more and more in the US. There are robust efforts worldwide to curb malaria transmission, and we're going to talk about a few of those today. The WHO approved the RTS vaccine in October of 2001 for children in sub-Saharan Africa and other regions with moderate to high transmission. And that was based on studies of children in Ghana, Kenya, and Malawi. And then the WHO approved the R21 vaccine in October of 2023 based on a phase 3 trial in Burkina Faso, Kenya, Mali, and Tanzania. So 2 malaria vaccines in fairly recent years. The RTS vaccine is a recombinant fusion protein, and the R21 vaccine is a virus-like protein. And I'm not going to get into the nitty-gritty of the science behind the vaccines because those are their own lectures, but both vaccines showed initial efficacy, pretty good initial efficacy, with a drop in protection over time. And so we're still teasing out the recommended schedule for some of these vaccines, but there are places where seasonal dosing is recommended. So malaria vaccines are a breakthrough for child health and malaria control. The vaccine has been very effective. Overall, amongst kids that are vaccinated, there's been a 40% reduction in uncomplicated malaria, as well as a 30% reduction in severe malaria. Of those who took the vaccine, early childhood deaths are down 13%. And there's a large drop in hospitalizations due to severe malaria. So really good effects from these. And then the demand for malaria vaccines is unprecedented, and scale up is well underway. At least 30 countries in Africa plan to introduce malaria vaccines. And this is truly a remarkable breakthrough in malaria care that will surely affect our healthcare in Kentucky. So let's talk about another disease expansion due to climate change. The CDC issued a Health Alert Network health advisory regarding increased risk of dengue virus infections in the United States in 2024. This year, global rates of dengue virus are the highest on record. In 2023, there was 4.6 million cases in the countries in the Americas. So 4.6 million cases in the Americas in 2023. But just from January through June of this year, there are 9.7 million cases in the Americas. Puerto Rico has declared a public health emergency, and they have 15,000 cases. And US travelers have brought 745 cases back home. So that's a lot of dengue. Dengue is a nationally notifiable disease. 6 US territories and states are classified as areas with frequent or continuous dengue transmission. In the rest of the US, there's been local transmission of dengue virus and sporadic outbreaks in Florida, Hawaii, and Texas. There's also been transmission in Arizona and California over the last 2 years. This is not just a foreign disease. This is a disease that is rapidly rising due to a changing environment and changing habitat for the Aedes mosquito. So with dengue infections, there are 4 serotypes. Each serotype provides long-term protection for itself, but there's only transient cross-protection between serotypes. Those who get an infection with a second serotype, so if you had serotype 1 before and now you get serotype 2, those are people at highest risk for severe disease and high mortality. So really the second instance of infection with dengue is the dangerous one. The rate of severe 3rd and 4th infections is actually quite low, so it's really the second one that's concerning. There has recently been commercially available vaccines, and the one approved in the United States is called Dengvaxia, and this was approved in 2018 by the WHO, and in 2019, the US FDA approved the vaccine for those in endemic areas. In 2021, the Advisory Council on Immunization Practices approved the vaccine for those ages 9 through 16 with evidence of previous dengue infection, so not for people who didn't have dengue before, and those who live in US endemic areas. Unfortunately, the vaccine manufacturing was discontinued in May of this year due to low demand. So just recently, this vaccine was discontinued in terms of manufacturing. It's still available in stockpiles, but we'll see what happens in the future. Clearly, there's a lot more hurdles that need to be overcome in the battle against dengue virus. So this disease outbreak talk would not be complete without discussing COVID-19. And we've seen about 7 million deaths due to COVID. And the true excess death toll is likely much higher. More than 17,000 healthcare workers died in the first year from COVID. And this has been the largest hit to the global economy since World War II, and the greatest economic contraction since the Great Depression. It has been due in large part to a lack of preparedness. The inability to take preparation seriously, combined with population growth, environmental changes, and global travel, put the world at risk for a zoonotic infection to be introduced into the population. The first case in the US was in a person who arrived on January 15th, 2020, and tested positive 6 days later. By the first week of March, the epidemic in the US was doubling every 2.7 days, suggesting rapid, uncontrolled spread. And on March 13th, the government declared the pandemic an emergency. So countries who had less deaths took precautions earlier. This bought time to collect information and develop a cohesive approach. And for many countries, it was not until they had already seen widespread local transmission and their hospitals were starting to fill with desperately ill patients that they finally took action. Healthcare facilities all around the world weren't ready for such spread. Ambulances were waiting in line to reach emergency departments that were too full, and once in the hospital, patients had to wait in EDs as inpatient beds were in short supply. There are many examples of systems that were many times over capacity. And as the pandemic developed, PPE became needed in quantities not seen before. The world needed 40% more PPE than could be produced. And PPE became very expensive. The dark bars are pre-pandemic prices, and the pink and red bars are the average and maximum prices of PPE during the pandemic. High prices leads to loss of access, and loss of access leads to inequity. So as you all know, healthcare wasn't the only part of society that had a problem to deal with. School and business shutdowns in most areas of the world had a devastating effect on the welfare of the younger population. In 2020, UNESCO estimated that $10 trillion in lost lifetime earnings for the current generation of students. 2021, UNESCO met again and determined that they were wrong. The estimates were actually $17 trillion, which is equivalent to 14% of today's global GDP. Inequity was and is clearly magnified during the pandemic. Worldwide, nearly 125 million people are living in poverty directly as a result of the pandemic. Because of lack of resources dedicated to an adaptable learning environment, an estimated 90% of students will suffer irreversible educational deficit. And those living without the ability to be educated at all rose from 50% to 70%. The inequity rift has focused more on females, underrepresented minorities, and the underprivileged. Globally, many females are at risk of never returning to school, and 10 million females are now at risk for early marriage due to the pandemic. There has been a sharp increase in gender-based violence. And job loss has been alarming, but women have lost jobs at a much higher rate than men. 39% of the global workforce are women, but 54% of newly unemployed people are women. So poverty and inequity are hitting hardest those who are already disadvantaged, females, impoverished, and children. And as said succinctly by the leader of the Shipibo Konibo community, if COVID doesn't kill me, hunger would. Throughout the world, food insecurity rates rose during the pandemic. The pink bars are 2019, and the red bars are 2021. Unfortunately, Most poor countries, mainly in Africa, had delayed access to COVID vaccines and is still catching up. The green areas on the map show high rates of COVID vaccines per capita, and the brown and red areas are low rates. And during the pandemic, rising vaccine misinformation meant decreased access to care and devastated economies. And this allowed for a large worldwide increase in the number of children who did not get appropriately vaccinated with routine immunizations. And it may or may not be a direct consequence of COVID, but missed vaccinations have real world consequences. Africa was declared free of indigenous wild polio in August of 2020 after eliminating all forms of wild polio from the region. But in 2022, the health authorities in Malawi declared an outbreak of wild polio virus type 1 after a case was detected in a young child in the capital of Lilongwe. And this was the first case of wild polio virus in Africa in more than 5 years. And in the United States, no endemic cases of polio caused by wild polio have been observed since 1979. And the Americas was declared polio-free in 1994. However, polio viruses, both wild and vaccine-derived, have been brought into the US by travelers. In June of 2022, poliovirus was confirmed in an unvaccinated, immunocompetent adult resident of Rockland County, New York, who is hospitalized with acute flaccid lower limb weakness. Circulating vaccine-derived polio was detected in the patient's stool, and it was also identified in wastewater samples in 2 neighboring New York counties, along with genetically related oral polio vaccine-derived viruses. So this reflects community transmission. The patient had not traveled internationally during the exposure period. Therefore, stool detection suggests that transmission originated in a person within the United States who was exposed to type 2 containing oral polio virus abroad. And oral polio virus vaccine was removed from the routine immunization schedule in the US in 2000, which means this had to come from international exposure. Unvaccinated individuals remain at risk for paralytic poliomyelitis if they are exposed to wild or vaccine-derived poliovirus. Global health is starting to become very domestic. We are seeing diseases previously eradicated due to poor vaccination rates. And medicine is a social science, and politics are nothing but medicine at a larger scale. So what can we do to prepare for the next outbreak? Well, we need to get our policymakers on board with listening to science. And we must have resources dedicated to responding to ever-changing needs in healthcare. We cannot differentiate the medical science from the social ecosystem. But we have the power to make change. People tend to trust their medical providers. People tend to trust us more than any other profession considered to be leaders. This graph depicts public confidence in different fields of service, including military, teachers, religious leaders, media, business leaders, elected officials. Confidence in medical scientists garnered the highest marks. We have a lot of power and a lot of responsibility. So today, I hope you all learned how disease spreads worldwide, how we as US providers need to keep learning and surveilling tropical illnesses, that we need to be at the forefront of medical information distribution, and our response to pathogens through surveillance, medical treatments, and public health measures will shape the outcome of infections. And perhaps most importantly, a world of inequity is a world at risk. Thank you very much.
All right, thank you, Dr. Blatt. That was extremely interesting. We have time for one question. What was the R naught of COVID, and how does that compare to the other viruses when there was not vaccine?
Yeah, great question. Let me pull up my little diagram that I made, and hopefully it was clear enough. So the R naught of COVID changed throughout the pandemic. So here we see measles is 13 to 18, Ebola is 2, influenza is about 1.3 on average. COVID really varied based on the variant and based on, and the RE based on, changed based on vaccines. So I think at its peak, I think with probably the Delta or the Omicron variant, I think maybe Omicron, COVID was up to about measles in terms of R naught. So it probably was around 15, 18, maybe even more in some studies. It's hard to know exactly. There was a lot of confounding factors because there was rapidly changing variants, because not all variants were monitored, and like people would be infected with different variants at different times. And there was vaccines circulating of different efficacies. But in general, COVID at one point in the beginning of the pandemic was an R naught of maybe 1.5, 2, and then later on in the pandemic it got up to 18. So and it's different now with the current variants.
All right. Thank you so much. Thanks for the lecture.
Yeah, happy to help.
Absolutely.